Verma. I'm senior resident in Dr. RML Hospital. In this video, we shall be studying about the X-ray, like the basics of X-ray, what is the systematic approach to diagnose any pathologies in the X-ray, and what are the various films which you can encounter in the exam during your PG examination. So friends, let's go and study about the X-ray. What is the basics of X-ray? As you all know, X-ray beam contain photons of various energies. These photons may penetrate directly to the film. Some might be absorbed completely by the patient, some might be absorbed partially by the patient, and some might be scattered outwards. So this is a primary X-ray photon. It can penetrate directly through the film. Some might be absorbed partly by the patient, and some might be scattered outwards. So what is differential absorption? Differential absorption is nothing but it means like different substances will appear like different colors in the X-ray film. Air will be seen as black, fat will be seen as dark gray, soft tissue will be seen as light gray, the bone will be seen as soft white, and the metallic part will be seen as a bright white part on the chest X-ray film. How to study the X-ray? Reading an X-ray can be easily done by mnemonic doctors A, B, C, D, E. DRS, A, B, C, D, E. The D stand for the details of the film, like demographics. Where was the X-ray conducted? What is the name of the patient? What is the type of the film? R stand for ripe, which tells you about the image quality. It tells you about the rotation, inspiration, picture, and exposure part. S stand for the soft tissues and the bone. A stand for the airway and the mediastinum. B stand for breathing. C stand for circulation. D stand for diaphragm, and E stand for the extras. All the gadgets which can be seen in the chest X-ray film, like endotracheal tube, tracheostomy, central line, chest tubes, and the Ryle's tube. So this is a systematic way in which we shall be discussing about the X-ray. So what are the type of the films which are available? We can be having a posterior to anterior film, PA film, anterior to posterior film, AP film, lateral decubitus film, apical film, lordotic film, and oblique film. So this is a most commonly film which is used. This is a PA film. It is most commonly done. This is an X-ray machine. This is an object, and this is a cassette. In this, the X-ray beams come from behind of the patient to the film plate which is placed in the front of the patient. And it gives an accurate assessment of the cardiac size. So this is how the PA films look like. It gives an accurate assessment of the cardiac size. So what all the structures which can be seen in the chest X-ray PA film. This is very important, and we must be aware of all the structures which can be seen in the chest X-ray film. This is a trachea, this is right lung, this is left lung, this is right bronchus, this is left bronchus, this is a cardiac shadow, this is a diaphragm, right hemidiaphragm, this is the left hemidiaphragm. These are the various angles, like costophrenic angle, cardiophrenic angle, this is a cardiophrenic angle, and this is a costophrenic angle. This is a stomach, and the gastric bubble can be seen here. This is how an AP film is done. And this is an object which is lying supine, and X-ray beam penetrates from the front to the cassette which is placed behind. It is mostly done in the emergency settings, ICU settings, and in the bedridden patient who cannot stand. And there is apparent cardiomegaly. In this film, you can see the heart is enlarged. It is because it is an AP film, which is done in the supine position. So how do we differentiate between a PA film and the AP film? By looking at the X-ray. In this, you can see this is a PA film and this is an AP film. PA film, as we have studied, is done routinely. AP film is done in the emergency settings, ICU setting, and the bedridden patient. In the PA film, we have studied that the X-ray beam penetrates from the back to the cassette which is placed in the front. X-ray beam penetrates from the front to the cassette which is placed in the back. It gives an accurate assessment of the cardiac size. But in the AP film, there is apparent cardiomegaly. The heart appears enlarged, which can be clearly seen here. In the PA film, the scapula are not seen in the chest X-ray part, in the lung field. But in the AP film, this is the medial border of the scapula. These are the medial borders of scapula, which can be seen overlapping the lung fields. The ribs are oblique here, clavicles are oblique here, but in the AP film, as the patient is lying supine, these are horizontals. Now comes the image quality part, R part, which stands for rotation. Rotation can be tell by whether the spinous process are at equal distance from the middle end of the clavicles. These are the spinous process and these are the middle borders of the clavicles. These are at the same distance. then the image is said to be not rotated. But in this case, in this film, on the right side, you can see that the medial border of the right clavicle is nearer to the spinous process as compared to the medial border of the left clavicle. So the image is said to be rotated. So this is a rotated X-ray film. Now, whether the film is inspiratory or expiratory, how can we tell that? We just have to count the number of ribs which are present above the diaphragm. This is an inspiratory film. See, these are the anterior rib. This one rib, 2 rib, 3 rib, 4 rib, 5th rib, and 6th rib. And these are the posterior ribs. These one are the posterior ribs. If 5 to 6 anterior ribs and 9 to 10 posterior ribs are above the diaphragm, then this is an inspiratory film. So we have to calculate the number of ribs. If we can calculate the ribs, then we can tell whether it is an inspiratory film or an expiratory film. Also, in the expiratory film, there is increase in the bronchovascular marking here. Also, and there is a crowding here, which can be seen. Picture quality. In this X-ray film, you can clearly say that the apex of the lung fields are not visible. So the picture quality is not good. Now, whether the X-ray film is underexposed, like this one, or overexposed, this one, this can be discussed by looking at the lung fields and the thoracic vertebra. And there's the lung appear more darker. You can see the lungs are more darker here, while the lungs are appear right here. You can see the thoracic vertebra here, but the thoracic vertebrae are not clearly seen here. So this is an overexposed film, while this is an underexposed film. Now comes the soft tissues part and bony part. In this, you can see that there is a break in the cortical lining, which denotes a fracture of the lip. The ribs are fractured here, 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 and this side. So this is an X-ray film showing the left-sided rib fractures. This is an X-ray of pediatric age group. The child presented to the emergency with severe vitamin D deficiency, and he was having rickets. So when an X-ray was done, you can see that there are beaded enlargement at the costochondral junction. This is nothing but this is known as rachitic rosary. So you can see there are rachitic rosary which can be seen at the costochondral junction in a patient with vitamin deficiency. So the child was given injection of arachidol and calcium supplements was given to resolve this. This is an X-ray film of subcutaneous emphysema. In subcutaneous emphysema, what happens is there is a collection of air in the subcutaneous tissue. And so multiple air pockets like can be seen throughout the X-ray. These are all the air pockets which are seen as hyperlucency in the chest X-ray. Most of the subcutaneous emphysema resolve on its own and nothing has to be done. But sometimes surgical may be given for the evacuation of these gases. This is an airway. We are discussing about the airway part now. This is the trachea. This is the right bronchus, left bronchus. This is the carina part. In this, you can see that the trachea is in the midline. But sometimes what happens is the trachea is not in the midline. The trachea is not here, rather the trachea is here. This is the air part, air shadow. What happens here is that there is a disease in the right side of the lung, which can be collapsed. Because of this collapse, the trachea is pulled towards the same side. So the trachea is not in the neutral, not in the midline, rather it is stretched toward the right side. This is an AP view of the neck showing fetal cyanosis. You can see that there is a decrease in the lumen or the caliber of the trachea here. So this is nothing but a sign of tracheal cyanosis. The lumen is normal here, the lumen is normal here, but there is a constriction here, which is nothing but tracheal cyanosis. Now comes the breathing part. In breathing part, the lungs feel a scan from the apex to the base. We'll be scanning the lung field from the apex to the base, like right upper lobe, middle lobe, and lower lobe, and left upper lobe, and the left lower lobe. Any kind of radio opacity in the chest X-ray can be due to consolidation, it can be due to collapse, or it can be due to effusion. So what is a Silhouette sign? Silhouette sign says if two areas of similar density are placed next to each other, they will blend into one shadow on the chest X-ray and the border will be lost. Obviously, two areas of similar density are placed, then the borders will be lost and they will blend into each other. So this is nothing a Silhouette sign. So if right hemidiaphragm is not visible, we will say that there is a disease in the right lower lobe of the lung. If the left hemidiaphragm is not visible, we can say that there is a disease in the left lower lobe of the lung. In this X-ray, you can see that the right hemidiaphragm is not visible. So there is a Silhouette sign here. So it is nothing but it is a right lower lobe consolidation. And this you can see that the left hemidiaphragm is not visible and there is a left lower lobe consolidation. So what is consolidation now? Consolidation is nothing but it is filling of the alveolar air spaces with the fluid. The fluid can be due to exudate, it can be due to transudate, it can be blood, it can be proteins, and it can be various infiltration. What happens in consolidation, as you're discussing, the alveolar air spaces become filled with the fluid. As we all know that the air spaces appear as black, while the fluid will appear as a white. So we can see small airways as black against a white background. So this is an X-ray film showing consolidation. There is consolidation here and this is air bronchogram here. So we can see airways are black against the white background. So this is nothing but known as air bronchogram. Consolidation mostly occurs in patients with pneumonia, but it has to be correlated with fever, increase in the counts, etc. But there are certain cardinal features of consolidation as well, which can be direct sign and indirect sign. In this X-ray film, you can see that there is a right upper lobe consolidation. As there is a right upper lobe consolidation, there is increase in the opacity here. And the fissure is displaced also. Along with this, the hilum and the trachea is displayed over the same side. There is also elevation of the hemidiaphragm. Along with this, all the remaining part of the lung, this one and this lung, this one, as these are normal, so there will be hyperinflation of the remaining part of the lung. So these are the cardinal features of the consolidation. This is an X-ray film showing right-sided pleural effusion. So in this, there is a collection of fluid in the pleural cavity, and this X-ray was in a standing position. So the fluid will settle down with the gravity, and there will be a sign which is known as meniscus sign. In this, you can see that there is a blunting of the right costophrenic angle, while the left costophrenic angle is normal. There is homogeneous opacity here, and the right hemidiaphragm is not visible, while the left hemidiaphragm is visible, and the costophrenic angles are also very clear. But in the right side, there is blunting here. So this is nothing but this is a meniscus sign. This is an X-ray film showing pneumothorax. In this, you can see that there is a loss of bronchovascular marking here, or area of hypertranslucency here, along with the collapsed part of the lung. This is a collapsed lung here. So this is a X-ray film of pneumothorax, which is mostly done and treated by ICD insertion. We have to insert the ICD in the 4th to 5th intercostal space in the anterior or the mid-axillary line, mostly done in the area of triangle of safety, which is nothing but it is wounded posteriorly by the latissimus dorsi, anteriorly by the pectoralis major, and inferiorly it is wounded by the superior part of the rib. So ICDs are inserted and the air is evacuated. So this is how a pneumothorax is treated, and this is how the film of pneumothorax look like on the chest X-ray. Now we shall be discussing about the cardiac silhouette. In this, we shall be discussing about the site, size, shape, shadows, and the bodies of the heart. This is an X-ray film, and there's a heart is on the left side. It is here middle part, mesocardia, and this is on the right side, dextrocardia. Levocardia, mesocardia, and dextrocardia. Now comes the size. The size can be calculated by the CT ratio. CT ratio is nothing but it is a maximum diameter of the cardiac part to the maximum internal diameter of the chest. Maximum diameter of the heart to the maximum internal diameter of the chest. The ratio is calculated. If the ratio is less than 0.5, it is said to be normal. If the ratio is more than 0.5, it is known as cardiomegaly. And this you can see that there is increase in the diameter of the cardiac part. So there is an increase in the cardiac width. So there will be cardiomegaly. What are the various bodies of the heart which can be seen in the chest X-ray? This is a cardiac shadow. Right side is formed by the SVC, right atrium, and IVC, and the left side is formed by the aortic arch, pulmonary trunk, and the left atrium and the left ventricle. So this is how we can identify the various bodies of the heart on the chest X-ray. It is a very interesting X-ray of a patient with cyanotic heart disease, pediatric age group, known as tetralogy of Fallot. In tetralogy of Fallot, there are 4 things. Like there is pulmonary stenosis leading to pulmonary oligemia, there is right ventricular hypertrophy, there is ventricular septal defect, and there is an overriding of the heart. So when the X-ray was done of this patient, the heart looked like a boot-shaped heart. It looks like a boot-shaped heart, like this one. So this is the boot shape part, which is a characteristic finding in patient with tetralogy of Fallot. So this is a very important exam-related question which can be asked in patient with cyanotic heart disease with TOF. Now we shall be studying about the diaphragm. This is how the normal diaphragm look like. This is right diaphragm. This is left side of diaphragm. We can see the gastric bubble here as it is in the standing position. We have to make sure of the claustrophrenic angle here, cardiophrenic angle here. Normally, the right side of the diaphragm is above the left side of the diaphragm because of the presence of the liver beneath. In this X-ray, you can clearly see that there is air beneath the diaphragm. Air beneath the diaphragm is nothing but it is a sign of perforation, which is an emergency. So this is an X-ray showing pneumoperitoneum. So this is how an X-ray of pneumoperitoneums look like. Now comes the last part, which is extra. Extra is nothing but all the gadgets which can be seen in the X-ray. As you all know that the endotracheal tube has a radiopaque line, so it can be seen on the chest X-ray. This radiopaque line is nothing but it is made of barium sulfate, because of it the chest X-ray can be used to identify the position of the endotracheal tube. So this is the endotracheal tube. Normally the endotracheal tube is present 3 to 5 centimeter above the carina. This is the carina, it is present 3 to 5 centimeter above. But sometimes what happens if there is endobronchial intubation, the tube can go inside the right bronchus, leading to the inflation of this part, and this part is not aerated. So there is a right endobronchial intubation. So this is an X-ray film showing right endobronchial intubation. We must be aware that after the central line is placed, we always ask to get a chest X-ray done. Chest X-ray is done to localize the tip of the central line. This is how the normal, this is the central line which is inserted by the IJV route, and this is where the tip of the central line is present. It is normally present near the carina region. But sometimes what happens is the central line go deep inside, like this one. The central line go deep inside and the tip is present within the cardiac part. So the tip is intracardiac. It is within the right ventricle. So the patient mostly present with arrhythmias. So we have to do nothing. We just have to pull it out. If we remove the central line or pull it out, then the arrhythmia will resolve on its own. So this is how the central line can be seen on the chest X-ray. This is an X-ray film of a pediatric age group having foreign body ingestion who present to the emergency with complaint of stridor. And there's when the X-ray was conducted, foreign body was seen in the AP view and the lateral view. This apparently looks like a coin. So the coin can be seen in the cricopharynx. So the patient was taken into the emergency and the coin was removed by the endoscopic procedure. So friends, thank you. I hope you understood this lecture of X-ray well. I tried to explain everything briefly, which is very important for the examination point of view. Thanks everyone.
Hello.
Hello. Yeah.
Yes, sir.
Thank you, Shikha, for a very nice talk on the X-rays, which was first prerequisite for a good PSC. And I hope the PGs must be benefited about the your explanation. Now I introduce Dr. Amrita Gupta. She's Associate Professor in SN Medical College, Agra. She will be, her area of interest is pain, and she will be speaking on Aldrich score.
Thank you, ma'am. Thank you.